All right, everyone. Well, we will go ahead and get started with this evening's installment of the AMSSM National Fellows Online Lecture Series. This evening's topic is Pediatric Fracture Care with Dr. Andrew Gregory. Before we get started, we'll go over the basic goals of the lecture. And so this lecture is presented by the AMSSM Online Fellows Education Subcommittee, Education Committee, and the Fellowship Committee. The goals are to serve as an adjunct to your individual program's educational programming, to provide fellows with direct access to educational experiences with experienced AMSSM members and at time invited guest experts in a variety of formats, and then of course assist in aiding fellows in their CAQ preparation. We ask for, during the time of this lecture, that you mute your device's microphone and turn off your videos. Throughout the course, if you have a question that arises, you can use the chat function to submit the questions. And if you want to include your name and your program, I'll collect those. And then during a Q&A period at the end of the presentation this evening, we'll present those and Dr. Gregory will answer them. And then following the completion of the program tonight, if you would like to complete an evaluation, that would be helpful for us going forward. So without further ado, as I mentioned, Pediatric Fracture Care Lecturer, Dr. Andrew Gregory. So Dr. Gregory completed his Bachelor's of Science in Chemistry from Indiana University and received his Doctorate of Medicine from the University of Alabama School of Medicine. He then went on to complete his pediatric residency at the University of Alabama in Birmingham before completing fellowship in primary care sports medicine at the American Sports Medicine Institute. He joined Vanderbilt faculty in August of 2001, where he sees pediatric sports medicine patients at both the Vanderbilt Sports Medicine Center and the Pediatric Orthopedic Clinic at Vanderbilt Children's Hospital. He currently serves on numerous academic roles, including as Associate Professor for Orthopedics, Neurosurgery, and Pediatrics. He's the co-director of Vanderbilt Sports Concussion Center. He's an Associate Professor with the Department of Orthopedic Surgery, as well as the Associate Director of the Sports Medicine Fellowship. Additionally, he provides sideline coverage as the team physician for Nashville Christian School, Vanderbilt University, the Nashville Sounds, and USA Volleyball national teams. So it is with great pleasure that I will turn the presentation over to Dr. Gregory to teach us about pediatric fracture care.
All right, thank you, Julie. Can you see my screen now?
Yes.
Okay. So thanks for the nice introduction. I appreciate the committee's asking me to present this topic, as this is something that is near and dear to my heart. I would say my own personal experience with it was that I didn't get a lot of it in residency training or fellowship training, and really had to learn it on the fly in my job setting, because it was something that we saw a lot of and I really hadn't been taught a lot about. So I hope to share some of that experience with you today. Let's see. Nothing to disclose regarding this other than I've had 3 known fractures in my life, so I might be biased. I'm not going to read through the practice gaps, but this is obviously something we all need to educate ourselves on. And my goal with this is really to help you be able to evaluate and treat common fractures, to distinguish between a fracture and a sprain, to describe some common types of cast, splints, and braces for fractures, and understand mechanisms of fracture. So we'll start off with a case. 10-year-old male with a wrist injury. He was playing flag football, fell, and complaining of pain in his wrist with swelling. On exam, he's got some mild swelling, but no obvious deformity. His motion is limited, and he's tender to palpation on his distal radius. The rest of his exam's normal. Here's his x-ray. And the challenge is for us to decide what to do with this. And oftentimes, if we have x-ray in our office, it's easy. We get an x-ray and we can look at it right away. Some of us don't have x-ray where we are, and they have to go and get an x-ray and come back, or maybe you only have access to a report even if they had the x-ray somewhere else and didn't bring it with them. And so I'd say it's quite common we're left in this setting. And I'm not going to point out anything about this x-ray other than I want you to see the growth plates are open and there's nothing obvious. So why is pediatric skeleton different It's relatively elastic and rubbery, so you can bend it without it breaking. The periosteum is very thick and active, which is a positive thing because it helps us with healing. It also can help stabilize fractures potentially. And if you look at the relative strength of ligament versus bone, in children, the ligaments are stronger than the bone, and that's an important idea. And having a growth plate in particular is a weak link. And so if we know that the presence of the growth plate being there, we should be more suspicious for fracture. One of my mentors, Dr. Neil Green, who unfortunately passed away, was famous for this line, which is kids don't sprain stuff. And if you remember one thing from tonight, that's what I would ask you to remember. Be suspicious of fractures in kids if their growth plates are open. And then the beautiful thing about taking care of kids is they heal really fast and they have this tremendous capacity to remodel, which I'll show you an example of. So here's a pediatric bone to define the anatomy of. I think we're all familiar with the growth plates at the end of the long bone. We may be less familiar with these other growth plates where the muscle tendon units attach, called apophyses. The epiphysis is the secondary growth center, usually forming the joint at the end of the long bone. The metaphysis is where the bone is changing into more cortical bone, which is the diaphysis. So another place we see injuries is at this junction of the cortical bone and more cancellous bone, where there are two different strengths right next to each other. So we talk about classification. I really try to simplify things and not make it too complicated, because classically, if we give doctors' names to these, we don't remember them well because they don't have any real meaning. So if you take these in order, the first thing that happens as you bend the bone is you can get what's called plastic deformation, where the bone is bent, but there's no obvious fracture. Typically, this occurs where you have two bones next to each other, like in the fibula or the ulna. The next thing that happens as you bend the bone is on the compression side, you get buckling of the bone, of the periosteum, which is a very stable construct if it's only buckled on one side. If you continue to bend the bone, you get a crack on the tension side, termed a green stick fracture. And I like this name because it explains something, which is like if you take a stick of celery and you snap it, it's still attached on one side. Again, pretty stable. Whereas if you take a dead stick and you break it, it breaks all the way through, which is a complete fracture. And you can have different orientations of that. I would argue these are the easy ones because they're obvious. It's these other ones that are more subtle that are oftentimes hard to sort out. Another classification that is different than these is the growth plate fracture, or physeal fracture. And we do assign doctors' names to those, Salter Harris, which we'll talk about the numerical classification of. And then those apophyses where the muscle tendon units attach, because of a lot of tension, they can pull off a growth plate called an avulsion fracture, which again can be hard if it is not very widened or not very displaced. So let's look at some examples of these. Obvious tibia fracture, you can see an oblique alignment to this complete fracture with some angulation, open growth plates at either end, but more kind of obtuse is this bowing of the fibula. And you can see that there's enough bowing that even the fibula has some malalignment to it. So plastic deformation. The buccal or torus fracture. So this is the geometry of the torus, which is how it gets its name. Some people like the idea of the Greek column, but here's an example of this. So this is a pediatric wrist. You can see open growth plate, and you can see this bump. And this bump occurs right where this cancellous bone that has no cortical thickening turns into the diaphyseal bone, where you can see the cortex is much thicker. So it's away from the growth plate. You can see there's another little one here on the ulna. And I would argue these are oftentimes quite subtle, just like this, that it's not something that's obvious, even less obvious than this at times. And so you have to be suspicious for it. And if you know where to look, it makes it easier. So again, proceeding with this, the next one is the green stick fracture. So if you look on this lateral x-ray of a kid's wrist, again, open growth plate, you see there's a buckling on the dorsal aspect, and on the volar aspect, there's this crack. But if you follow the crack, it doesn't go all the way through. A good example of a green stick fracture. You can see it's really minimally displaced. This is what it looks like on the AP view. Again, you can see the crack, but you can't follow it all the way through the cortex on the other side. Again, this is stable because one side is attached. And then several examples of the complete fractures. Again, I tell people you don't need a medical degree to be able to see these. These are not hard to pick up. Most of these are going to be somewhat displaced and may need realignment, typically in the emergency room so they can get sedation. So again, most of what we see is not these things. It's the more subtle ones. So let's talk about Salter-Harris classification. Again, this is at the end of the long bone, so it involves the growth plate. So if it just goes through the growth plate, that's termed a Salter 1. If it goes through the growth plate and part of the metaphysis, that's termed a Salter-Harris 2. If it goes through the growth plate and part of the epiphysis, that's termed a Salter-Harris 3. If it goes through both the metaphysis and the epiphysis, that's termed a 4. And if it's a crush injury, that is termed a 5. Now, to me, again, this numerical system is a little bit confusing because it's not like it has any real prognostic value. What I would try to simplify this is, does the fracture go into the joint or not? So the 3s and 4s go into the joint, the 1s and 2s do not, and the 5, which is more rare, actually has a much poorer prognosis because of destruction of the growth plate. And a lot of times we don't know that's what it was even until retrospect. And then displacement matters. So the numerical system has no sort of reference for displacement. So you can have a displacement of Salter-Harris 1 and it's worse than a non-displaced Salter-Harris 4. So that's why I say the numerical system doesn't necessarily give you prognosis. If you diagnose a 3 or 4 or a 5, to me, those are ones that should be referred to surgeons because they really need to be aligned perfectly. Whereas a 1 or a 2 can be treated conservatively and they do quite well. So what about some clues to fractures? Kids have this bad rap of not being good historians. My argument is they know exactly what happened. It's whether they trust you to tell you or not. And so I try to tease it out of them, and oftentimes they can give you a pretty good story. But I would say any fall, you should be suspicious. Kids fall all the time, but any fall, if they're complaining of pain, then I would be alert. But here's the bad actors: trampolines, monkey bars, and anything with wheels. I would say are top mechanisms. And you may not have anything obvious to look at. There may not be obvious swelling, bruising, or deformity. And so it may be more subtle that they're not wanting to put weight on it, or they're limping on it, or they're just protecting their arm. But I'd say monkey bars, every kid has to cross them in order to graduate from elementary school, but really good for business. So again, I want to spend some time on the subtle fractures. So the non-displaced physeal fracture, the buccal fractures, the avulsion fractures. Occult fractures are a real thing, which is there's a fracture there and we can't see it because there's no displacement. And then there are some other things in kids just to be aware of. Nursemaid's elbow, which is more of a traction injury, which we'll talk about, and then other causes of limp, whether that's avascular necrosis, an inflammation, or an infection. So we'll start off with the elbow. I think the elbow is particularly difficult because of the number of growth plates, but it has a clue, which is swelling. And so we're looking for swelling in the joint. What swelling in the joint causes is a loss of ability to flex and extend, but it does not affect your ability to supinate and pronate. We know statistically that fractures in the young, meaning school-age kid, is typically supracondylar, and then in the older child or adolescent is more common in the radial head. So if you know that ahead of time, it kind of helps you knowing where to look. Here's the mnemonic for these growth plates. And what I tell people about this is just remembering that they appear in an order and they disappear in a different order. And if you're ever unsure, there's nothing wrong with x-raying the other elbow just for comparison view. But this is the order with which they appear. And you can see every 2 years you get a new growth plate. And then once they all appear, they start to fuse. The medial one is the last one to close, usually around 15 to 16 in boys. So you can see this can go well into high school. Here they are pictorically, so capitellum, radial head, internal, trochlear, olecranon, and then external. These three fuse, followed by the radial head and the olecranon, and then again, the medial epicondyle is the last to close. So here's this clue that I was mentioning, which is evaluating for an effusion. And because you have these fat pads in your elbow, it makes things easier to see. And so you have two fat pads, one in the front, one in the back. The challenge with the one in the front is it can be normal if it's laying flat against the humerus, but it's abnormal if it's elevated, termed sail sign. And I like this idea. So if you Understand sailing, there's a mast, there's a sail on the front and the back. If there's no wind in the sails will sit flat against the mast. If there's wind in the sails, they billow out away from the mast. So if you ever see a posterior one, it's abnormal, and the reason is you have an olecranon fossa. The fat pad sits in the fossa normally. If there's fluid, it gets pushed out of the fossa where you can see it. So the idea here is if you have trauma, your elbow swells, that's blood in the joint. And so in that setting, you have a fracture of one of the bones that approximates the joint. So whether that's the distal humerus, the proximal radius, or ulna. And so if you see a fat pad, you know there's a fracture. The question is, where is it? So here it is diagrammatically. Again, you can see the humerus is the mast. The posterior fat pad is sitting in the olecranon fossa. The anterior one is sitting against the humerus. And then if you fill up the joint, both these fat pads get pushed away. And so it looks easy on this, but when you start looking at x-rays, some of them are less obvious. Here's an example of an elbow lateral view where the growth plates are closed, but you can see these two black shadows. The effusion is harder to see because it's the same density of the soft tissue, so you can't really differentiate it, but very, very clear on this particular example. We'll look at some other ones that may be less so. So here's a lateral view. I would say it's not a perfect lateral view, but you can see this black shadow here in the back. A little harder to see in the front, but no obvious fracture in a child with open growth plates. So again, in the setting of trauma, this is blood, there's a fracture. If you're really astute, you might say there's a little bit of an anterior cortical break right there, but I'd say very subtle. Another example, this is a lateral view in a child where the radial head is a little harder to see. You can see obvious elevation of the fat pads here, but I would say no obvious fracture. This is a younger kid, so you would assume it's supracondylar. So he was treated in a splint for a week, followed by a long arm cast for 3 weeks, and then here's his x-ray at 4 weeks. And what you see now is this callus going up the posterior humerus. And so he had a supracondylar fracture that we just couldn't see. So the fat pad alone is enough to cause you to initiate treatment in the right setting. Again, a less good x-ray in that it's a slight oblique, and so the fat pads are a little harder to see. So if you really want to see them well, you need a good lateral view. Again, you can see a very slight cortical disruption there. So again, in the school-age kid, I'd be thinking supracondylar fracture. Here's the AP view, and you can barely make it out there. But again, the lack of displacement here is what makes it hard to see, but it also means they can be treated conservatively because it's non-displaced. Another good example of a fracture that was not visible initially. So this kid had x-rays that were read as normal and was not treated, came back 2 weeks later with continued elbow pain, and here's his repeat x-ray. And what you can see is there's a fracture line here on the radial neck going into the physis and some early callus, so a healing radial head fracture. I mentioned one of the imitators as being Nursemaid's elbow. Should probably be called babysitter's elbow now. But the idea here is this is a young child who you're holding their arm. They may not want to go and are pulling you the other way, and you give them a little help, and there's a pop, and immediately they have pain. I put on here fallen outstretched hand. Once this has happened once, the mechanism can be much easier for this to happen again. So if you have somebody with a fall, I would argue they need an x-ray to rule out a fracture. If you have a clear traction injury, then I think you can proceed with a reduction. Typically, the child will hold their arm against their chest, but they'll kind of go about their normal business and keep playing. No obvious swelling, but if you leave it alone, it doesn't get better. So what is this exactly? It's a subluxation of the radial head because of a small tear in the annular ligament, which slides off the radial head and into the joint. So average age is toddler age, 2 to 4 years, described up to age 8, but I'd say that's pretty unusual. And what happens is the radial head changes its shape from being like a pencil eraser to that of a hammerhead around age 5 to 6, and then the ligament can't slip off anymore, so they do outgrow it. So here's the idea: it gets pulled on, this tears and slips off, and then you let go, and then it's trapped in the joint, which is why supination and pronation is so painful. Hope you get the sound effects. So what about reduction? This is a relatively straightforward thing to do. There's really 2 well-described ways of reducing it. One is with supination and full flexion. The other is with pronation and full extension. And what I tell people is pick a way and do it well. You really don't need to do it both ways. You shouldn't have to repeat it. Usually when it's unsuccessful, it's because you haven't supinated all the way or you haven't flexed all the way. And so the idea here is that it does hurt very briefly. And the longer it's been out, the longer they tend to be sore afterwards, even after it's put back in place. So moving on down from the elbows to the forearm and wrist, and this is important because it's one of the most common fractures in kids, and it may be becoming more common. So if you look at studies out of the Midwest, the fracture rate is actually going up. And whether that's because of body weight, poor nutrition is unclear, more activity, we really don't know. But most common mechanism is fall on an outstretched hand. There may be no obvious clues, but where they're tender is on their radius, just proximal to the end of the joint. If you have them go through their motion, they usually have a loss of supination, or they may have pretty good motion if it's a buccal fracture. One clue is if you see this bruise on the volar wrist, and if you fall on your hand and you scrape up your hand, you're going to get bruising down in your hand. But if you see a bruise here, that bruise is from a distal radius fracture, so it's a good clue. So here's a good example. This is a kid who fell on their wrist, complained of pain, had an x-ray that was read as normal, follows up 2 weeks later with continued pain, and you can see there's this callus here on the distal radius on either side. So this was a fracture went through the physis, but it wasn't visible because it was non-displaced. So healing fracture. Here's an example of an older child. So you can see again, open growth plates to the distal radius and ulna. There's an obvious ulnar styloid fracture here, but a less obvious problem of the radius. But this is a good clue for you. If you see an ulnar styloid fracture, those don't happen in isolation. You know there's a distal radius fracture with it. And if you look on the lateral, maybe there's some slight buckling. I'd say that's not as obvious because of where the ulna is overlapping, but I think you can see this little line here. And again, I chose some subtle ones because I just want you to be aware that a lot of the time these are subtle, they're not obvious. Another good example where you have ulnar styloid fracture visible on the AP, slight buckling, I'd say, of the radius, but nothing obvious. On the lateral, a little more obvious. So you can see this buckling of the dorsal cortex and a crack on the volar side. So the thumb orients you on the lateral view. These tend to be, the buckling is on the dorsal cortex because of how you land on your hand. Another good example of a buccal fracture, both distal radius and ulna on the AP, that you can also see on the lateral. So buccal fracture of the distal radius, one of the most common fractures we see. Several randomized controlled trials now showing that a cock-up wrist splint, which is what is in these pictures, is as good as a cast for prevention of fracture and prevention of loss of alignment. No difference in bane control, better function, and then they don't have to come back for cast removal or get a new x-ray. So this has really changed practice where everybody used to get casting for this. Now we know they do just as well in splints, and not only is it better functionally, but it's cheaper for the patient. So this is what we recommend for all buccal fractures of the distal radius now. So this is an example of remodeling. This is my neighbor down the street. She fell while riding her bike and sustained this fracture of her distal radius. And you can see the fracture goes through the physis and through the metaphysis. So this is a Salter-Harris 2 fracture. And you can see it's slightly dorsally displaced. So this volar aspect of the epiphysis should line up with the metaphysis, and you can see it's pushed back by almost a centimeter. So she went to the emergency room. They tried to reduce this. They were unable to do so. And you can see it's splinted in this same position. So we left it there and put her in a cast after a week. And here she is 4 weeks later. And you can see this callus that's formed on both the volar and dorsal aspects of the metaphysis. And then we brought her back in 5 months. So 6 months out from her injury. And you can see how she's remodeled this fracture. You can see, you barely see kind of where it was in the volar and distal aspects. So these don't have to be perfect if it doesn't involve the joint. And then this is just a reminder that we most commonly see fractures of the distal radius, but we cannot forget about the scaphoid, even though patients with open growth plates. So here's a good example, open growth plate here. with a mid-waist scaphoid fracture that you can see. And then this kid was the child of our scheduler in our clinic, and he's a high school football player, fell in spring practice and injured his wrist. Mom thought it was likely a sprain, and so didn't get him x-rayed. And then when he came back to summer practice, was continuing to have wrist pain and got his x-ray. And you can see here this proximal third scaphoid fracture that went on to non-union, and yet his growth plates are still open. So snuff box tenderness in a child has the same importance as it does an adult. They should be placed in a thumb spica. And these are ones that I would refer because they don't heal well, unlike those buccal fractures. And then finger fractures, the jammed finger, as I think we're all aware, is not a diagnosis. It's a mechanism of injury. So either you sprained it or you broke it, and there's really only one good way to tell, and that's x-ray. And so I would say in a kid, so high school and younger, that deserves getting an x-ray because you really can't tell if the growth plates are open without the x-ray. So several examples. Here's a volar plate avulsion fracture. Here's an ulnar collateral ligament avulsion, and then a Salter-Harris fracture that goes through the physis and then through the epiphysis. So again, very, very common injuries in kids because the tendons and the ligaments tend to pull off these fracture fragments. This is one I'd refer because it involves a joint. These two I think you can treat because they're non-displaced and small. So moving down the lower extremity, the slipped capital femoral epiphysis, you might argue, isn't necessarily thought of as a fracture because it could be more of a stress injury, but I think it's something that is really important to be aware of. It's a fracture through that proximal femoral physis, and any child who has a limp and or hip or knee pain, you should be thinking about this. The way you diagnose this was as an AP and frog leg of the pelvis, not a hip. And the idea here is by ordering a pelvis, you get both sides so you can compare them. And the whole goal is to catch them before they slip. Again, if it's obvious and it's displaced, it means it's too late to save that hip, and quite frequently bilateral. This is one of the few things in our world in pediatric orthopedics where every one of these is going to get operated on. They're going to get pinned in place. You really can't reduce it. And oftentimes they're going to pin the opposite side just prophylactically. So here's an example of this. This is an x-ray of the hip. The ice cream has fallen off the cone. It's too late to save this kid's hip. We cannot feel good about this diagnosis. However, if we compare that to this kid, so this is a frog leg pelvis view, and if you compare the left side to the right side, you see this growth plate looks normal, this growth plate looks wide, but then if you draw a Klein's line, which is a line on the superior aspect of the femoral neck, it does not pass through this epiphysis here. So here the ice cream is starting to melt, but it hasn't fallen off the cone yet. We diagnose in this kid, put him on crutches so it doesn't become this, and call your surgeon. They're going to probably see him that day and operate on him the next day. Other common fractures around the hip and pelvis are avulsion fractures. So if you have a teenage athlete who feels a pop and immediate pain while either sprinting or kicking, you should be entertaining this diagnosis. The reason is these growth plates are often some of the last to close. So again, quite common in teenagers, even into college. And it's a mimicker of muscle strain. So because adults strain their muscles all the time, their assumption is that, well, the similar mechanism in a kid is probably the same thing, but it isn't. And so in this setting, you want to get pelvis x-rays to see these. So here's several good examples. You can see open growth plates here, proximal femur, trochanters, triradiate cartilage all open. And you can see there's an avulsion fracture of the anterior inferior spine at the origin of the rectus femoris. You see how close that is to the acetabulum. Here's an example of a ischial tuberosity avulsion fracture in a dancer from kicking. You can compare that to the opposite side. You can see her proximal femoral growth plates are all closed, but her ischial tuberosity is still open. An example of a lesser trochanter avulsion fracture, again, I would say these growth plates are just about closed, if not all the way. You can see the iliac crest is still open, but if you compare the lesser trochanter over here to over there, you can see it's been avulsed off. Again, this was a sprinting injury with a pop. So all these are going to be treated with rest, crutches until pain-free, and then allow them to walk, but don't allow them to run or jump or kick until they are pain-free, typically, or excuse me, until they have healing on their x-ray, typically at 4 to 6 weeks. Moving on down to the distal femur. Again, a common fracture is this supracondylar fracture or physeal fracture of the distal femur. Typically, this is a running injury. They slip and fall, and they're tender at the physis or above it. Really swelling doesn't help you, but they don't want to bear weight. You don't see any obvious swelling in the joint, and it's considered a form of a toddler's fracture because it's quite common when kids are young. And you can see again in this case, there's just subtle buckling of the dorsal cortex of the distal femur there. In this child, you know this is a young child because the patella hasn't ossified yet. And here they are in follow-up with some callus. This is a middle school football player who had a blow to the lateral knee, felt a pop, and was thought to have an MCL sprain. And luckily, because he couldn't bear weight on it, came in for x-rays, and you can see there's a fracture here that goes through the physis, excuse me, and down into the epiphysis, so into the joint. So this is one of the ones you really want to worry about, because if this doesn't get reduced well, this can affect growth of this physis and arthritis in the joint. So this is a Saltaris 3, and you can see this went on for surgery with a pin that did not cross the physis. See the AP in the lateral. Also around the knee is the proximal tibia. And again, these often can be subtle injuries, but what they describe is a pop and pain around the knee. And you have to distinguish a fracture from other injuries, but they're going to be tender on the physis again. So instead of being tender on the distal fibula, or excuse me, femur, this child was tender on the distal tibia and, or excuse me, proximal tibia and the proximal fibula. You can see there's a very subtle fracture of the fibula here and a fracture that goes through this physis. There's a small metaphyseal piece here. So this is a Saltaris 2 fracture. And then finally, the more common toddler's fracture. So this is a typical mechanism is a toddler who has a fall and refuses to bear weight. Oftentimes not really thought to be a significant mechanism, a trip over a toy or a slip on a bathroom floor that's wet. And immediately they won't bear weight. In this case, you should get an x-ray, but you should still be suspicious even if the x-ray is normal, or even if the exam doesn't produce much if the kid won't bear weight. And so here's several examples of these. So this is this oblique fracture here, the distal tibia. You can see a more subtle one. And then here is more common example where the x-ray is completely normal. This kid got put in a walking boot for 3 weeks, and then here's his x-ray when he comes back, and you can see some callus here way up on the tibial shaft, and you can see sclerosis here in the distal tibia. So that's what a healing toddler's fracture of the tibia looks like. So moving on down to the ankle, the growth plate of the tibia and fibula are located just 1 inch above the distal malleolar tips, both medially and laterally. Most common injury you see is a Saltaris fracture of the distal fibula because of the inversion injury, just like you see in ankle sprains in adults, you see in inversion injuries in kids cause fracture with the same mechanism. The external rotation stress can be very helpful, just like it's helpful in an adult to try to distinguish these. But I would say tenderness to palpation at the physis is probably the most useful thing. And then remember, when these growth plates close, the tibia closes medial to lateral before the fibula, and this is going to be important for certain fracture patterns that you see in the adolescent. So here is a stress view, and I'm not advocating we do this, but I'm using this for educational purposes. That you can see the growth plate of the tibia appears closed. The growth plate of the fibula appears open, but it doesn't appear obviously abnormal. But when you put this kid under stress, your ATF, your CF, and your PTF ligaments are all holding the epiphysis, and you can see how the physis widens. So that is the mechanism of injury that you're seeing there under stress view. Distal fibula Saltaris 1. Here's some other examples that are similar. This is a younger child who's playing soccer, was fallen onto, twisting the ankle, had immediate pain, couldn't bear weight. These were the initial x-rays, read as normal, which I think is true, but was very tender here on the distal tibia, just 1 inch proximal from the tip of the malleolus. And so we assumed this was broken, put this kid in a walking boot, and here he is 3 weeks later. And you can see this obvious callus on the lateral aspect of the distal femur, and a little less obvious here on the medial aspect and on the anterior aspect. So this was a Saltaris 1 fracture that you couldn't see initially because it was non-displaced. Here's an example of a Saltaris 2 fracture. Again, a little more obvious. Again, does not go into the joint, so this could be treated conservatively with a walking boot or a cast. And then this is the one that I was telling you that you need to be aware of in the adolescent. So what's happening here is the tibia is closing medial to lateral. So this part of the growth plate's closed, but this part is still open. And so what the fracture does is avoid the part that's closed, and it goes into the joint. And then you can see on the lateral view, it goes all the way up here into the metaphysis. So this is a Saltaris 4 fracture, but it's important because it goes into the joint, and these often can be more displaced than they appear on x-ray. So this is one that I would refer, and typically they're going to get a CT scan to see how much displacement it is, but a lot of times they get fixed because they go into the joint. And then finally is the foot. So calcaneal fractures are, again, notoriously difficult to diagnose because of this cancellous bone. It's cancellous on purpose to pad us for jumping and running. But if you jump from a height or jump into water that's more shallow than you thought it was, that's a good way to break your heel. This is the original x-ray on this kid who came in with heel pain after jumping into shallow water, was placed in a walking boot, and then you can see his x-ray 4 weeks later where he has clear callus there within the bone, a healing fracture. Sometimes these can be bilateral and they have to be put in 2 walking boots, which is unfortunate. And then moving on down to the foot, and I didn't mention this in the hand, but the same is true of the foot and the hand, that in the metacarpals and metatarsals, the growth plates are distal on 2 through 5 and proximal on 1. So if you know that, that's helpful in trying to sort out where the fractures might be. And so here's a good example of a Saltaris 2 fracture, the proximal first metatarsal. And you can see the slight kind of disruption of the cortex here. In this case, the ossification center isn't very visible, so it's hard to tell that it goes down into the growth plate. You can see these ossification centers haven't even shown up yet. And then the 5th metatarsal has an apophysis, and this can often lead to kind of confusion as to whether this is a fracture or not. So you can see these other growth plates are open. This is a normal appearance of the apophysis. This is a normal appearance of the apophysis. So they can get pain there because of the attachment of the peroneus brevis tendon pulling on it and causing a traction injury. Or you can have an acute injury. So if they invert their ankle and they feel a pop, then you worry that they could pull that growth plate off. And so oftentimes there's pretty obvious swelling and bruising and pain, and they can't walk. It's worth kind of classifying these 5th metatarsal fractures because, again, this can be a point of confusion. If you have an avulsion fracture, that's going to be proximal to the joint between the 4th and the 5th. The apophyseal avulsion you can see quite clearly based on the growth plate that we were just looking at. And then the Jones fracture is a little different from both of those in that it occurs in this watershed area here, which is the joint between the 4th and the 5th, where the blood supply is not very good. And those are the ones that don't heal well. The apophyseal avulsions heal well. The true avulsions without the growth plate heal well. The shafts heal well, but the Jones don't. So again, if you know that and you can predict that's the one that doesn't heal well, those are the ones that I would send to my orthopedic surgery colleagues. So here's some examples. This is an avulsion fracture. You can see pretty close to that joint, but proximal to it. And then here where this one goes into it. So again, this is a true Jones, and this is a pseudo Jones fracture. So what about some basics about casting and splinting? The general idea with these is both to control pain and to promote healing, but you have to be careful because if they're not put on correctly, it could cause problems. And I think there is a study showing that about 60% of braces and splints are put on incorrectly. And so if they're too tight or too loose, those are both situations where they can cause pain. If the position is improper, so if the splint is placed so that it ends right at the level of the fracture, obviously that's not doing what you want it to. And so it could actually make the pain worse because of the weight of the splint. But in general, your goal is to include the joint above and below if you're unsure. For distal long bone fractures, sometimes you can get away without including the joint more proximally. But if unsure, it's always better to immobilize both. So if you compress too much, that's where you really cause problems. So it causes swelling distally, so in the hand, in the foot. In severe cases, you can get neurovascular compromise and pressure ulcers. So we always tell people when we put them in splints, hey, if you have swelling, you need to loosen this thing. Don't wait. And if you're having significant pain in it that's worse than before, then I worry about a pressure ulcer. So one of the things we know about in kids with fractures is their pain typically only lasts for 2 to 3 days if they're splinted or braced correctly. And so if you have a kid who's having pain that goes beyond that or increasing pain, then I would say that deserves a check to see if their splint is on correctly or not. The idea of splinting initially and not casting is because of the risk of swelling. So if you put them in a splint, their swelling gets worse. But there are certain fractures that really don't swell much. The buccal fracture, which we talked about, the toddler's fracture we talked about, so they can go into their splint or boot right away, and that's definitive care. So usually we splint them for a week. We see them back in about another week once the swelling's gone down, and then put them in a cast if indicated. Time for reduction is worth understanding. It does not have to be the next day, but usually within about a week or week and a half so that they don't start to heal. And then we want to encourage them to move their fingers and toes because, again, that helps with swelling. That helps with some kind of numbness and tingling they might have. And if you do put them in a cast, they really need to understand they can't get it wet. Certainly there are newer casting materials that allow you to get them wet, but then you have to dry them out. But these are expensive and in most parts of the world not available. We tend to use these during the summer months when the swimming pools are open. So we call them swimming casts. I don't like the term waterproof because it implies that you don't have to worry about it at all or ever get it dry. But if you've ever seen what the skin looks like after a wet cotton padded cast, really the skin is more of an issue than the fracture itself. So here's a good couple examples of pressure sores in the heel. These are very common places to get them because of improperly applied splints. So you want to make sure that when you're putting on a lower leg splint that you pad the heel. And then you want to make sure that the heel is in a neutral position. If you put them in plantar flexion, what tends to happen is the kid pulls back on their leg and puts more pressure on it, where if they're at a right angle, they really can't pull out of it. And so again, once you have these pressure ulcers, these are going to take much longer to heal than the actual fracture itself and cause much more pain. So what about some bad actors? Again, these obviously displaced fractures are going to need to go into the emergency room for reduction. A supracondylar fracture that's displaced, so I'd say if it's obvious and not subtle, then you should be calling up your pediatric orthopedic colleague. A lateral condyle fracture, so that's what this is an example of, where this whole capitellum has kind of come off with a chunk of cartilage. And if these don't get reduced, they tend to cause lots of problems with motion and function later. Mid-shaft forearm fractures, just like this one, if they get reduced, oftentimes they're hard to keep reduced, so they're very unstable. And so again, these are ones that I would probably refer on for management. I already mentioned the Salter-Harris 3s and 4s. Any fracture that involves the cartilage itself. So these are classically fractures that you might see with a patellar dislocation. And then I mentioned the scaphoid or navicular fractures. These are all ones that I would refer. So in summary, be suspicious. An appropriate mechanism in a child with bony tenderness is probably a fracture. And if in doubt, put them in a splint and then recheck them in a week with a repeat exam. You may or may not want to repeat the x-ray. Usually a week, it's really not that much different. And then if you have a child who's limping or not using an extremity without a clear mechanism of injury, then I would start thinking about other etiologies. I mentioned inflammation, infarction, and infection. So other things to think about. So as a result of this, I would hope that you would consider ordering more x-rays in your young athletes who get injured, and that you would read the x-ray yourself, because oftentimes these are subtle and the radiologist is at a huge disadvantage because they don't know where the kid hurts. And then trust your clinical judgment. If the x-ray is normal, but yet the story's right and they hurt like it's a fracture, then I would treat it that way. So I think I ended on time. I appreciate everybody joining in tonight. I hope that everybody is able to get outside and do activities that they enjoy in this difficult time. But I'll open things up for questions. So thank you, Julie.
Of course, great talk. So one of the first questions is, in the case of pediatric fractures, when do you typically advance or when do you need advanced imaging?
So that's a fair question. So I mentioned the CT scan in the setting of a fracture that goes into the joint. I'd say that's always a good idea if you are concerned and you really want to see how much displacement. A CT scan is very useful. Certain times MRI can be very helpful, like if you have a hemarthrosis in the knee and you just can't really get a good exam, you can't tell if their ACL's out, you can't really tell if they have bony tenderness just because everything hurts. An MRI will show an occult fracture very well. I would always start with x-ray, but if your x-ray doesn't answer the question, you could consider advanced imaging. Typically what we do if the x-ray is normal is we just treat them and then bring them back and re-examine them in a week and then make a decision. And if it's still unclear, then maybe you consider an MRI.
Okay, great. Do you ever get any pushback or concern from parents about radiation exposure with repeat imaging despite initial imaging being negative?
Yeah, so that's a fair question. So I would say in general, in our hands, if we see somebody who has an x-ray initially and it's normal, we see them back at a week and they're still tender, we're going to treat them with a cast and then we bring them back and get an x-ray at the end of treatment. We're not going to repeat that x-ray then. If I have a fracture that's been reduced and I want to know is it still in a good position, that's when I'm going to repeat their x-ray. In general, and it may have to do with the region of the country I'm in, I'm oftentimes having to talk parents out of x-rays versus talking them into it. So it's not been a huge problem where I am.
Okay, great. Another question was if you could elaborate on how you determine which Salter-Harris fractures need long-term physial checks.
So that's a great question. I did not address at all. So if you see a Salter-Harris fracture with any displacement, then I would argue that they need to have a repeat x-ray at 6 and 12 months to check the growth. The ones that are really the ones that cause the biggest problems are the distal femur, the proximal tibia, and then the radius. And so those are the ones that I would pay particular attention to. So a Salter-Harris fracture in the finger, the toe, would not be one I would say needs follow-up because it isn't going to really cause a major problem. But any displacement in a Salter-Harris fracture in a long bone, I would say deserves follow-up at 6 and 12 months.
Okay, great. And then just one final question was, you talked on the splinting for distal radius fractures being non-inferior to casting. Have they shown anything with cam-type walking boots and fibular fractures rather than casting?
So that's a great question. I don't think that study has been done yet. I think it should be done. I do think in general, walking boots initially versus a splint or a cast tend to cause less problems, meaning you don't see pressure ulcers with walking boots. I also think, unfortunately, walking boots get overused. And so a lot of times when people don't know what's going on, they stick them in a boot. And then if you aren't careful, it's hard to get them out of the boot. So I didn't mention this when I was talking about immobilization, but our immobilization period, we want to shorten that as short as we can make it to see healing and then get them out and get them moving. So there is detriment to immobilization. The bad things that happen are you get stiffness of the joint, you get atrophy of the muscle, you get osteopenia of the bone, and then if you leave it on there long enough, you start to affect the nerve, and that's how you get complex regional pain syndrome. So I do like the idea of the boot, but I'm always telling people, make sure you're following them up and getting them out of the boot, because otherwise the boot may cause you more problems than it helps.
Well, those were all of the questions we have. So thank you so much for a wonderful lecture. Lots for all of those fellows out there, lots of really pertinent CAQ pearls in this one. So definitely one worth watching again. But thank you again. We appreciated having you. For everyone who's in attendance, there is a link in the chat function just to give us feedback on the lectures so we can always continue to improve them. But otherwise, everyone can have a great night.
Thanks a lot, Julie.
Thank you.
We do have one more question in the chat if you're still able to answer that, Dr. Gregory.
Yeah, I'm still here.
Yeah, so one more question was just if you have seen that NSAIDs have caused a delay in fracture healing time.
Yeah, so great question. I mentioned that in kids, they typically don't have a lot of pain for very long. So the first thing I would say is we don't use narcotics. I can't remember the last time I wrote a narcotic prescription for a fracture in a young adult or a child. And so with NSAIDs, they tend to treat their pain just as well as a narcotic with much less side effect. And because they don't have pain very long, they're not using the NSAID very long. And so I would say the answer is no. The one time that I would be concerned about that is with a scaphoid fracture, because we know they don't heal well. And so I would particularly counsel them, if they're having continued pain, not to use an anti-inflammatory, but to use Tylenol and ice and elevation. But it's a great question. In kids, they really in general heal very well and don't have pain very long. So that's not a problem that we see.
Great. I think that's the last one, but I can hang around in case there's another one that pops up. But thank you again.
Yeah, thanks. Have a good night.